high works.
All right. All right, now I unplugged this.
And you're ready to go.
All right. Hi, everybody. Thank you so much for having me. And part of what you'll be hearing tonight is that physical therapists are like the heroines and heroes of our service. So you'll find out why. Does the little thing have to be in the middle of the picture there? Okay. Great. So this comes from it's a slideshow that is sponsored by the American Academy of Addiction Psychiatry. They have a series of educational things on pain. So this is one of them, and I'm going to skip over some of the slides here so that you guys get what fits for what you're thinking about. For example, toll-like receptors for opioids on the glial cells, we'll brush by that lightly. All right, so one of the things about my talks is that I have never taken a pen or a can of Coke from a drug company, and the result is that I find that my suggestions are actually quite different from many of my colleagues. All right, okay, so what are we going to do? We're going to learn, as people come to see you, so many of them are on opioids. Why is that? And we're going to define opioid-induced hyperalgesia, learn something about how it's produced, learn what happens to people on methadone or buprenorphine maintenance, know how fast it happens, know what to do about it, and then we're going to discuss how do you know if someone has opioid addiction versus they happen to be just taking the drug all the time. And then I thought I would make a slide or two for you guys about, as a physical therapist, how do you want to deal with people on opioids? All right, so I'm not going to read you a lot of the slides. They were written so that you didn't have to have a speaker. So you don't have to, I'll just tell you what's on some of these slides. But you can see that we live in a tiny bubble of prescribing here in the United States. And you'll notice that people come from India or other places, and they are shocked at the amount of opioid prescribing that goes on. So we have 5% of the world's population, and we're currently consuming 99% of the world's hydrocodone. So what's up with Americans here? All right, and you can also see that the deaths have gone up. So in 1998, 14 people in the United States died from oxycodone, and by 2005, it was over 1,000. So, like, what's up with that? All right, so here's the answer. There was a social movement in the United States in the 80s and 90s called the Right to Pain Treatment Movement. So before, I guess, maybe 1980, doctors used to be really careful and worried that opioids had tremendous addiction potential. Now, think about this for a minute. Suppose oxycodone had a 0.01% chance that people would get Stevens-Johnson syndrome or hypertension or something. It would be regarded as a horrible side effect. They would yank that oxycodone right off the market. Well, suppose about a third of the people who took oxycodone got addicted to it. Well, that's the patient's fault, obviously. It's got nothing to do with the drug. So there's an enormous side effect from opioids, and this weird thinking, which makes no sense to you guys as well as me, is if there's a vicious, awful, significant side effect and the patient gets it, it's the patient's fault. And this is the Right to Pain Treatment group in I think it's a 2007 paper explaining that this is a fundamental right. If people have pain, they must get opioids. It's a basic human right. They'll say things like, doctors like me should be put in prison. It's elder abuse if patients are not given opioids. And this kind of an attitude just took over in the United States in the 80s and 90s. So there's a current discussion. For the first time, I get to speak to the medical students for the teaching in the pain section, which hither up until this point, the medical students have been told opioids are the best drug we have for pain, and if someone ruptured or herniated a intervertebral disc in 1993 and it's 20 years later, how could you withhold a drug like this? This, which you definitely can't read from what you are, is a doctor saying in the 90s the chance of getting addicted to opioids is less than 1%. No one dies from this drug. If you take too much, you'll just go to sleep, and that will end your drug taking. And here's the inflection point. You can't really see it, but this is oxycodone prescribing in New York State, and where I just pointed is 1996. And here is deaths. If you were concerned about heroin, you don't really have to worry about it. Heroin is these green bars, and over this period from 1999 to 2010, there's no more heroin use or deaths than there always had been. If you look at the blue, this cocaine, it went up for a little while, but then it came back down again, and then you can see the gold bars are deaths from opioids. All right, so what we find in the United States is cars are getting safer. The number of motor vehicle fatalities has gone down. Prescription medications are getting much more dangerous, so they've now replaced motor vehicle accidents as a leading cause of accidental death in the United States. All right, so that's the big picture. So now let's go on to what is opioid-induced hyperalgesia. My best understanding of reading papers is there was no such thing in the 20th century. There were reports, but no one really understood this back in the last century. And it's just pain made worse by opioids. So there's two concepts here. One is tolerance. So if you had a pain in your knee and you took 5 milligrams of oxycodone 3 times a day and it worked great, if you develop tolerance, you might have to take 10 milligrams a day 3 times a day and it would work great. So it just takes more to have the same effect. Opioid-induced hyperalgesia has to do with transforming the pain system. Back in the 20th century, doctors were very confident that we had the technology with opioid medications to squash the pain system. By now, we understand that the brain rebels. Pain is a basic survival thing. So if it was 10,000 years ago and you stepped on a thorn and you couldn't feel the pain, you could die of a bacterial infection. It's a survival thing. If you squash the brain's pain system, the brain just amps up its pain drivers, in fact, overshoots, so that it can continue to feel pain. So, let's see. I had to quote these guys in the first textbook I've seen on opioid-induced hyperalgesia that came out in 2010. I'll read it. If addiction and the relief of suffering are partners in an uneasy marriage where opiates are concerned, then opioid-induced hyperalgesia is the mother-in-law whose role in the union may be ambiguous, but whose presence is never in doubt. How do you know it exists? Well, one easy way is you take people off opioids. It doesn't matter if they're a 19-year-old who's shooting dope or a 49-year-old who's been on oxycodone. You take the drug away, everything hurts. The pain system is upregulated by opioids. All right, so this is a thing you don't have to read. It's saying that this is the first picture I've ever seen, and it was a beautiful explanation by this guy, Solarier. I'm going to take a step back. This is just where the opioid receptors are. So there are opioid receptors in the brain. This is what knocks out your ability to have the full pain experience. There are also opioid receptors in the spine. There are opioid receptors in the gut. There are opioid receptors on the white blood cells. So if you know the details, what you know is if you hit your thumb with a hammer, you get an inflammatory response with cytokines. And a few hours later, white blood cells start to come in with opioids on their membranes, and everything in the brain or the body is constantly balanced homeostatically. So you get the painful inflammatory response, and then you get the diminishing opioid response through the white blood cell. So my contention is that opioids should be regarded as a hormone, just like the body makes thyroid hormone, estrogen, testosterone, cortisol. It's made in the central nervous system, and it's also made in the adrenal. It circulates through the blood. It has various receptor sites all over. And what happens if you take an exogenous hormone? Well, if you're a woman and you take exogenous estrogen, you knock out your ability to get pregnant by suppressing endogenous estrogen production. If you're one of these male cartoonish weightlifters you see at the gym and you inject testosterone, you shut down the testicles' ability to make testosterone. If you take exogenous opioids, you shut down brain morphine. The brain makes morphine. Now, unfortunately, the guy who invented the term endorphin, Solomon Snyder, he says, in the 1970s, we knew that opiates had to have a receptor in the brain, so damn it, we were going to find it. We found it. We found the agonist. It's a series of peptides, and we started to call them endogenous morphine, but we decided to make a contraction endorphin. So there's endorphins, enkephalins, dynorphin. Unfortunately, the convention in English is when you invent something scientifically, you switch to some sort of bizarre Greek name to confuse everybody. That's just a medical convention in the English language. So instead of brain morphine, which you'll constantly hear me call it, it's endorphin, enkephalin, dynorphin. So it confuses you in terms of thinking of it as a hormone. So why in opioid withdrawal does everyone have nausea, vomiting, diarrhea, gut cramps? It's because the opioids are circulating through the blood. There's receptors in the gut, and their job is to slow peristalsis. Acetylcholine drives peristalsis. Opioids slow it. So in intoxication, like you have a patient on oxycodone 20 QID, they're constipated. The brake on the gut is terribly enhanced. If they didn't take it for a couple of days, they're pooping on the way to their physical therapy appointment. All right, so here's the central and adrenal source of opioids. Here's the balancing. This is a substance P emitting sensory neuron coming into the spinal cord with endorphin or endogenous morphine or enkephalin, suppressing adventitious signals. So if your body is functioning normal, neurons want to fire, and all these pain neurons are firing constantly, and your own morphine is damping the pain signals, and everything feels okay. But this is why if you take opioids away by suppressing them, everything starts to hurt. All right, so these are some of the more technical points. Now, this is a cartoon of mine. I have some papers explaining the upper and downer pathway for addiction. So everyone looking over there instead of at me, and I just realized that's another screen. Okay, so let me come over here and explain. By 2013, we understand that there's an opioid withdrawal syndrome, which is punishing and makes people want to stay on the drug. There are emotional reasons that I think we'll get to in a minute that people would want to take opioids. But the nature of addictive drugs, what makes them addictive is they can shift the dopamine function from the ventral tegmental area to the nucleus accumbens shell. So this is a basal forebrain pathway. I'm going to call the ventral tegmental area the midbrain, the VTA. It's in all of us animals, so we go look for food, water, and sex. So let me just ask, animals have brains and plants don't. What's up with that? Why don't plants have brains? They stay put. Excellent answer. So the reproductive strategy of the plant is you make 1,000 seeds, and animals or the wind carries them to 1,000 different places, and one seed is in the right place, and there's the next tree. If you're an animal, you have to move through your environment to go find stuff so that you can live and reproduce. This is 21st century Freudian metapsychology. So the basal forebrain bundle is where this track runs, and then the nucleus accumbens shell is constantly feeding information up to the prefrontal cortex. I saw food somewhere. It was there and then it was gone. What makes those red things grow on the ground, and they're there in June and they're gone in July. These are strawberries, but you didn't know that. And eventually you start to organize cues so that you don't starve to death. The leaves are a certain green in June, and the air smells a certain way, and the light is a certain way, and the sky is a certain color, and this pathway is organized so if you find something with survival potential, you can organize the cues that it's present, and then if those cues are noticed, glutamate comes right in here and it turns on craving. Do you crave strawberries if it's 10,000 years ago in February? No. April? No. June? You start to get these signals. Go out and look for strawberries. It must be that time. It turns on your craving, your seeking. All addictive drugs have to turn on this pathway in order to turn on craving. So if it's cocaine, nicotine, or methamphetamine, it's blocking this pathway right here, which I call the upper pathway. So the famous one is cocaine. Why does the coca plant make cocaine? What's in it for the plant? It's a complex molecule, takes energy to make it. It makes it because, oh my goodness, cocaine is an everyday thing, guys. It's a natural insecticide. So if you're a bug in South America, you're happy to eat all the other leaves except for the coca plant leaves. If you eat them, it's a neurotoxin. It turns on your dopamine and it kills your brain. So cocaine as a toxin poisons the dopamine reuptake transporter protein, which is a natural recycling. The dopamine comes to the synaptic cleft. It irritates the nucleus accumbens shell, so it fires. It gets sucked back up with the transporter protein into the presynaptic neuron. It's a nice recycling thing that maintains your dopamine at the right level. You take cocaine, there's no way for the dopamine to get back in, or norepinephrine or acetylcholine. So you're all jazzed up for a while because of this poisoning that you're undergoing, which may or may not be pleasant, but there's a change in this pathway, and after an exposure or a few, you start to look for cues that your coke dealer is around. It's the way it works. All right, how about the back pathway? Now, this is for alcohol, all the downers, opioids, alcohol, marijuana. There is a constant balance in the brain, so the drivers need to have some sort of a break. So it's this inner neuron here, GABA-aminobutyric acid, is a inhibiting neurotransmitter. It's constantly, neurons want to fire, it's constantly slowing down the VTA. All the downer drugs paralyze the brake. So they're not as addicting, right? It's always harder to get off nicotine than heroin or oxycodone. You see more people who inhale nicotine get addicted to it, or more people who inhale cocaine get addicted to it than people on opioids or benzos or alcohol. But it's going to capture some people. It's going to change their brain. So if you have a patient, if you have 100 people who are exposed to oxycodone, a certain percentage of them are going to start to fiend for the drug because of brain changes that were induced by their fabulous, right-to-pain treatment, deeply empathic physician. All right, so what happens with pain tolerance? So this is the one I meant to get to before, but obviously I didn't plan my slides right. Here's Dr. Solarier in 2001 putting a rat on heroin, and every day it takes less pressure for the rat to squeak in pain when he squeezes the paw. And once he lets this die away, if he gives a single dose of heroin, then the rat is very pain sensitive. It's like there are two states now induced in the brain. There's the normal state and the hyperalgesic state. And the hyperalgesic state goes away, but it can be quickly reinstated by the drug. So what this means is if you work with your patients to get off the damn oxycodone and they twist their ankle and go to the emergency department and get 5 oxycodone just for an ankle twist, they're going to reinstate the hyperalgesia, which probably takes months to go away. Here's Solarier, this brilliant guy, blocking the glutamate system and showing that glutamate is a driver of opioid-induced hyperalgesia. Glutamate is just another simple neurotransmitter. So by 2013, we understand what causes addiction neurobiologically. We understand what causes opioid-induced hyperalgesia. It's a little more complicated than that, but there are other drivers of pain. So there's a gamish of different things like substance P and dynorphin and corticotrophin releasing factor. But the bottom line is that you can create it in animals. So this is one example of thousands. You implant a rat or a group of rats with morphine, a continuous release, and that you fry the feet, and the control rats jump right off the hot plate. The morphine rats say, something's going on, I should probably move off. They're much slower, but by day 4, they're jumping off faster than the control rats. It hurts more. And this is the George Koob theoretical model. Every oxycodone helps, every morphine helps. That's the A process. The B process, which no one is conscious of, is the pain system resetting at a more intense level. So this goes on as people are exposed to more and longer opioids. Their pain drivers are being upregulated, and yet they have the experience they have to take an oxycodone or it really, really hurts. And they're absolutely telling the truth. The pain is getting worse and worse and worse, and it's induced by the opioid medications. All right, here's the toll-like receptors that we're skipping. Here's some of the drivers of opioid-induced hyperalgesia. All right, so what's happening with humans? Well, this is the cold pressure test that we do on my service. We do it every Wednesday. It's a very complex technical thing that requires me to go to Wegmans supermarket every Tuesday night and buy 28 pounds of ice. And the rest of the equipment includes a beer cooler. So I throw the ice in the big beer cooler with a little bit of water, and our patients just stick their forearm under the ice with a little water, and it really hurts. But what we find is that with our particular beer cooler technical setup that includes a pump so that warm water doesn't build up around your arm, the average time for normal controls is 102 seconds. 95% of the subjects can hold their arm in at least 35 seconds. It really hurts. You guys would probably all be 3 minutes because you're so competitive. So everyone's got a little bit different beer coolers. You know, some places probably have some $1,000 tank, but anyway, here's a report. 56 is average for this guy White's controls. And when they're on methadone, their times are 15 seconds. So they're having to pull their arm out much faster. Along with Hay and some other people, he did it over again because there's a myth in the pain treatment world that this doesn't happen if the opioid is given for pain, only if it's taken for addiction. I've heard that a number of times. I never heard anyone cite where they got that information, but so these guys found this time they got their control average down to 31 seconds. Must have been really cool or really well stirred. But it didn't matter if you were on morphine or methadone. It didn't matter if you were on methadone for pain or methadone for addiction. Everybody had a time 18, 19, or 20 seconds. So they had to pull their arm out faster. And this is on opioids. This is people, you know, if you guys took as much methadone as these subjects, we wouldn't be able to wake you up for a day. So there's something else going on. You know, you would think if you took morphine, you know, people could punch me in the face and I wouldn't care, but something else is going on with these patients. All right, so how do you diagnose opioid-induced hyperalgesia? The person must have been maintained on opioids, and we'll discuss how long, and either the pain is worse despite no new source of pain, or the cold pressure time is shorter, and you guys don't measure that routinely, or the dose of opioid goes up and up. So you're not seeing patients on 5 milligrams TID of oxycodone. You're seeing them on 20 TID and 40 QID. And we had a patient today who was telling us that he's got a friend that he buys his Opana from, which is oxymorphone. It's the really cool drug after OxyContin. No one wants OxyContin anymore. They want Opanas. Oxymorphone is 8 times more milligram potent than morphine, so this woman was getting prescribed the equivalent of 1,000 milligrams of morphine a day. Now, the border of high-dose prescribing is 180. This doctor was giving her 1,000. Who can afford to take that much oxymorphone? I mean, you have to sell some of it, right? All right, so here are just randomly the first 6 people we did the cold pressure test on, and you can see their time, 3 seconds, 10 seconds, 14 seconds, 5 seconds. Here's a 17-year-old woman who hasn't been on opioids that long, 180 seconds. And the last guy got admitted to University Hospital because he had a peripheral nerve injury, and he just took more and more and more fixed-dose ibuprofen and some opioid until he went into renal failure. His time was 10 seconds. We detoxed him, and a week later, his time was 3 minutes. and his pain was gone. So he'd gotten into that A and B thing, and by the time we met him, his pain was generated by the opioid. The original injury had resolved, or was so minimal that, the pain was turned on, but it wasn't significant. Now, does it go away? So here's a very good researcher, Wren, showing that people who had been off heroin for 5 months, their cold pressor time is still significantly lower. You can also see everyone's tank is different. Our average is 102 seconds, and his average is 134 seconds, but it's a very significant difference. So one worry that I have, which is not shared by many physicians, is, you would think the brain is like a rubber band. You stretch it one way with oxycodone, and you take the oxycodone away, and it goes just back to where it was. I'm worried it's more like silly putty. You stretch it out, and it stays hyperalgesic. So it's possible, but no one knows the answer. We're doing the experiment on millions and millions of Americans. We may be creating long-term or possibly permanent hyperalgesia because we're giving out opioids so much. All right, and this guy Younger, who's part of the Stanford pain group, has now shown that when they do MRIs and they show brain changes in certain places, you put someone on morphine for back pain for a month, 5 months later the changes have not reversed. All right, what about people who are maintained on buprenorphine? I hope you know that since I don't take money from drug companies, I can't say Suboxone, but that's the street term. Methadone is so old and generic that I have no idea what the brand name used to be. But here's a 2012 paper showing people getting on, I think that's not Adam's phone, that's mine. Well, we'll just ignore it. There it is. Okay, so at baseline, these are people who are addicted to opioids, so they're already hyperalgesic. This little diamond is the 43 seconds. Now that's the average for this particular tank. People are coming in at 26 seconds, and as they're on buprenorphine longer, they're getting more hyperalgesic. So addiction maintenance patients, everything hurts. And they come into the hospital, they come to physical therapy, they're on methadone maintenance, they're very difficult to work with, everything hurts. You ask them to do the most basic stuff. They can't do it because they're so hyperalgesic. It's not addiction, they're not wimps. They've had a brain change. So this is an article from the Journal of the American Medical Association showing that for people on methadone maintenance for addiction, when they first start, they've already had a lot of opioid exposure. That's why they're on methadone maintenance. 22% of them have daily severe pain. By the time they've been on methadone maintenance for 2 years, it's doubled. All right, so how long does it take to induce opioid-induced hyperalgesia? So there are some recent papers about this. And the answer is you can do it in a day. And what this graph is showing is they looked at people who had various lengths and various exposures during one-day surgery. So remifentanil is like fentanyl on steroids. It's given intraoperatively. The people in the black area there were exposed to remifentanil for, if I remember, the biggest line is 7 hours for some complex back surgery. And what they're measuring is they were exposed intraoperatively, and then what kind of opioids do they need postoperatively. And these were very nicely done studies where some people got some intraoperative other form of analgesia. Why have to have analgesia while you're unconscious, I'm not sure, but that's what the surgeons do. All right, so what would you do if you had one of these patients? Well, first, this is Norman Miller's very nice study. Jaco forced him to ask people in his hospital every day, right to pain treatment, pain is the fifth vital sign, how bad is your pain? And he's running a detox in Michigan, so this is the kind of complaints he's got, mostly back pain. And this is just detoxing people in the hospital. On hydrocodone, the average pain score is just about 5 out of 10. And after a week, it's about 3 out of 10. Oxycodone is 7.5, down to 4.5. Detoxing people really helps their pain. So this is something we do. What would the mechanism be? Obviously, if you take away the thing that's causing the pain drivers to be so upregulated, pain gets better. The patients would never think this, and unless you understand this concept, the doctors wouldn't think this either. All right, so how do you know if people have addiction? Well, these are the official DSM-5 criteria, tolerance and withdrawal. Now, if you think about it, everybody who's maintained on oxycodone has tolerance and withdrawal. So that's so nonspecific. I'm the author of, I think at this point, 4 papers on, God damn it, could we please change the diagnostic criteria in addiction? And then taken in larger amounts over a longer period than intended, unsuccessful attempts to cut down or control. So you have all these people who they just can't get off the drug. And this is something I'm going to present for the first time at our annual addiction conference next month. But we've found a way to show that there's really 2 groups of people. There's a bunch of mostly older, nice, no psychopathology kind of people. They have tolerance and withdrawal, and they can't get off their drug. They come to our service. We have a very nice way to do it. Our completion rate is 92%. And they basically say, thank you very much. I'm never taking that drug again. Then we have a larger group who are 20 years younger on average, and they're the ones who are cruising emergency rooms and doing coke and, getting overdoses and so on. There really seem to be 2 groups of people, but the hallmark of addiction is you urgently want a drug that's harming you. So the classic way to think of it is cigarettes. Why are people inhaling nicotine, dirt, and carcinogen 20 times a day? What sense does that make? That's a longer discussion. I have a paper about that too. But the point is that they know it. They're having fantasies. I'm going to die of lung cancer just like my mother did. And they're inhaling the drug. That's addiction. So people are addicted to opioids. You suggest that maybe they'd be better off without the oxycodone, and it's, oh no, I need this from my pain doctor, which is why we have a pain service embedded in the addiction service here. All right, finally, opioid-induced hyperalgesia post-surgical, but this is, I think, very helpful for your practice too. So this is I think it's 2011 paper, and the blue lines are people who come in for surgery and have not been maintained on opioids. The red lines are people who were on opioids already. So, for example, Doc, I injured my back in 2004. That machine fell on me. So they've been on opioids since 2004, and now they come in for their back surgery versus whatever the surgical procedure is. They weren't maintained on opioids. So you can see on this graph the average score post-surgically, if you were not maintained on opioids, is 5 out of 10, and 2 weeks later, it's 3 out of 10. What's the driver of post-surgical pain? Come on, you guys are specialists here. It's swelling, right? The doctor goes in, slashes up some fascia and muscles, and it gets all swollen, and as the swelling goes down, the pain gets less. the average pain score for the people who were on opioids before they had the surgery is 7, and in 2 weeks, it's only down to 5 where everybody else was starting. All right, so I decided that was the slide to sort of then talk to you guys about what you see, because if I understand your practice, you have people coming for physical therapy constantly or maintained on opioids, and they're miserable to work with because, oh, no, don't make me do that. Oh, it hurts too much. All right, so one thing to tell them, since you just saw the slide about what the surgeons have to do, when we go to University Hospital and we do a lot of pain consultations, the constant question is this person addicted, and what do we do about it? They just, they were wrecked, they fell down the stairs and broke their leg. Now what do we do for pain? So what I always say is, number one, don't give opioids for pain. NSAIDs are at least as good and probably better, probably slightly more potent for pain, and dramatically less side effects. So if you can give NSAIDs, give them. But if you decided to give opioids, you have to give 2 or 3 times the usual amount. It's not drug-seeking. It's opioid-induced hyperalgesia. So if you're going to treat that person who fell down the stairs, you need to give them a lot. Now, in your setting, what you would say, oh, my God, you're on oxycodone 20 QID. Everything hurts. You have opioid-induced hyperalgesia. When you come for your physical therapy appointment, take 2 or 3 oxycodone. They're not going to stop breathing. They're tolerant. That's what I would tell your patients to do. And so the position that you want to get out of is they only took 20 milligrams of oxycodone, which, again, if you ever took it, you'd wake up tomorrow. But it's like nothing. They should take 2, and, if it's 20 QID, take 2, come to physical therapy, and have 2 more left over for crexing around after I made you do all this stuff that you really need to do to get better. Okay, consider all these other psychiatric, emotional issues, which I guess I didn't put in a slide there about opioids key into the endogenous morphine system, which we all use to regulate human interactions. So it's just amazing. People we detox have complaints like, essentially, doctor, I'm having a feeling, what should I do? The pills work great to get rid of the need for humans and to get rid of emotions. They really do that. So patients are going to be taking it, if you, one patient said to me, for example, doctor, that feeling you get in your heart when you're in love? That's how oxycodone feels. I have a graph I should have put in here. I'm sorry. It's an inverse U function. And what it says is you guys are well related. You're at the top of opioid tone in your central nervous system. A common response for people like you guys is, oh, I took 5 milligrams of oxycodone. It was awful. I never want to take it again. It's because if you go past the peak, you go into the dysphoric range. But if you're socially isolated, if you're depressed, if you have panic disorder, if your stepfather sexually abused you, if you were never able to talk to kids at school, you stay by yourself, you run low opioid tone, and you wrench your ankle, you go to the ED, they give you 5 milligrams of oxycodone, and you go up to the optimal point, and you say, this is the way I always should have felt. Now, when you go back to the doctor, you don't say, gee, it's really working for my depression. Can I have some more? You say, oh, my ankle still hurts, which you guys run into then when you're supposed to help them with their ankle. Coordinate with the physicians, be non-judgmental. So, here we go. I hope it's sort of becoming clear. Addiction is just another mental illness. It's horrible to have. If people have it, they can be shifty and difficult, but it's all psychopathology. So instead of feeling injured, you need to take a stance like, I'm so sorry you're doing this or that to get more opioid pills or to avoid physical therapy or whatever they're doing. It's part of their illness. And then suggest detox because it's going to help with their pain. Oh, I did have some more slides. So here's we're doing a meta-analysis. I've read about 400 comparisons, randomized double-blind studies of NSAIDs versus opioids, and this is just the typical one. This is people who come to the emergency room, 12 to 18, with a suspected fracture. Everyone's got this idea that opioids plus NSAIDs ought to be better, but that's not true. The ibuprofen is just as good as oxycodone in this study. This is one of my favorite things, and I have to explain it because the slides are not going to jump out like a picture. But here's people who, just like the other study, came to the emergency room for an injury, and they got either ketorolac, the brand name is Toradol, or they got morphine, and you can see that the pain scores with activity were much better with the ketorolac. The pain score went down more than 1 out of 10 and only 0.87, and the p-value is 0.003. But watch this. Look at these side effects. The ketorolac group, 5% of them had side effects. The morphine group, 89% of them had side effects. There's another study of renal calculi. You're passing a kidney stone. You could get morphine or ketorolac. After an hour, the people on ketorolac say, thanks very much, doc, see ya. The people on the morphine are laying on the floor puking. I mean, that's basically drowsiness, sleepiness, dizziness, nausea, vomiting. These are the side effects of opioids. And then this was a great thing that they threw in. How satisfied were you with how the emergency room was run? This is a randomized double-blind study. 6, 6. No difference. How satisfied were you with your analgesia? Ketorolac, 6 out of 10. Morphine, 5 out of 10. A very significant difference. Another study that I didn't put in here is what do doctors give patients in the emergency department based on their educational level? So this was a fabulous finding for patients with a doctoral level, which would be you guys. What do emergency department doctors prescribed? NSAIDs. For people who haven't gone to high school or graduated high school, what do they give them? Opioids. So if the doctor identifies with you, they think what doctors think. I wouldn't take this stuff. All right, and this is my last slide, so I'm sorry, but I had to get here because look at this. This has been on my service for years. What is the number one intervention for chronic pain on our service? Exercise and physical therapy. We just love physical therapists. We want our patients to go see you guys all the time. And then the other ones in the first rank are obviously NSAIDs and acetaminophen. And the combination of like 1,000 milligrams of aspirin and 1,000 milligrams of acetaminophen is going to be at least as good as any amount of morphine you can throw at the person. After that, low-dose tricyclics. This would be, nortriptyline 25. That's especially good for neuropathic rather than inflammatory pain. Antidepressants. Why? Because I would think the pain is the same if you're depressed or not, but the depressed people start to go, oh my God, my knee is hurting. Oh, what's wrong here? Oh, this must be really serious, which, if you're not depressed, you go, God damn it, my knee hurts. And anticonvulsants, this is gabapentin, is very popular on our service. Other doctors like pregabalin or topiramate. And then there's a bunch of other stuff here. that, they're all good. We send people over to our sister pain service down on Fly Road to get regional blocks. This topical diclofenac is great. You put the NSAID right where the pain is, yoga, massage, acupuncture, and then detoxification. And this is something we do on my service, which is unique in the world. I think we're going to be able to prove that we can change pain tolerance by doing the opposite of opioid-induced hyperalgesia. We block the opioid receptors transiently with 1/1000th of the usual dose of naltrexone that's used for alcohol dependence. And the patients, we had someone with fibromyalgia telling us today, she takes it at 6:30 in the morning, and she was so in pain and, fibrofog that she was taking modafinil to drive all the way here. And now she takes her low-dose naltrexone, and she has a spurt of energy first thing in the morning. So we have a publication about fibromyalgia last year that instead of getting into that A and B hyperalgesic process, we do the exact opposite. We block the opioid receptors, and we have a contrary thing where there's a rebound of your own brain morphine in response to having the receptors transiently blocked. So that's my talk, and I'd love you guys to make all your own comments here. Yeah.
So we have lost patients that are on these meds. Where our direction, you mentioned out at SUNY, oftentimes the pain clinics in town heavily prescribe opioids. You see them come in, people are on that post all the time. So are they getting more comfortable with this, or their shifts, or do we?
I think they're. All right. I'm sorry. So the question is, Karen says, "Oh my God, we're out there with all the orthopedic surgeons, and what do we do about the fact that they snow the patients with opioids and then they come to us? Is that a fair?" And the pain clinics. All right. So, I'm going to slightly talk out of school here and say that in terms of the university hospital pain service, where Sebastian Thomas right now is the head, and the pain fellows train on my service. And Sebastian is like my best non-psychiatric colleague at this point. He sends, every week we're seeing his patients, he gets a consult, which is what to do. If someone's been maintained on opioids for more than a month, they should get a consult. Is this a good idea? Is this helping? And we send them back a variety of answers. If the cold pressor time is 3 seconds, we go, oh my God, the oxycodone is making everything worse. If the cold pressure time is 90 seconds and the patient has been on a constant dose and they feel it's helpful and there's no sign of addiction, we send back a note that says, if it was me, I'd detox. If I was the patient, I wouldn't stay on this, but it's a matter of opinion, and there's no sign of addiction or hyperalgesia, so just continue the patient. Now I'm going to say the other thing, which is I'm trying to get in with the Syracuse orthopedic specialists in spine and wellness. And they have, in my mind, a hustle going. So SOS does the surgery, and they refer 400 patients a month to Spine and Wellness. Spine and Wellness maintains them on opioids. They have increasing hyperalgesia. So if you're me and you have a back patient, we do a physical exam. In fact, we had a patient who had a giant surgical scar and multiple consultations, and I examined him, and he says, you're the first doctor who's asked me to take my shirt off. So why do you get an MRI? We have patient handout number 4 is for imaging, and what are the indications? Now, there are 2 indications for imaging. One is you have a sudden motor impairment. You have foot drop. And that's something that I, like twice a year, tell the patients, go get surgery for. The other thing is you need to send your kids through college, and you need a lesion to show that surgery is indicated. So you do an MRI. And then you say, oh, my God, there's a bulging disc, a herniated disc, an annular tear. And you guys would treat this medically as physical therapists, and I would treat this medically, but surgeons would treat this surgically. So there's a huge amount of radiologic examination going on. What's $1,000 or $2,000 if it's somebody else's money? Who cares? And Spine and Wellness sends all their patients for radiologic exams to the SOS facility. So there's no direct kickback, but I met with the business manager and the chief doctor, Perry Cook, at SOS, and I gave him a pitch about let's follow people on my service and randomize them to Spine and Wellness and follow them for a year and see what happens. And Perry Cook said, we do have a research department here. I never heard from him again, no response to my follow-up emails, because as far as I can tell, there's all kinds of bonuses built in for patient visits. So if it's, how's your back? Bad, you need a little more oxycodone, here you are, that's $250. See you next month. Oh, it's really bad? Let's send you over to SOS for an MRI and find out what's really going on in that back where they operated in 2008. This is the kind of thing that's built into our system. You guys there's the eternal medical-surgical divide, right? So I'm medical, basically, as a psychiatrist. You guys are medical as physical therapists. You get deeply involved with patients, and it's a lot of work, and it's a lot of interaction, and you try to influence behavior. The surgical people, there's no particular reason to talk to someone if you're going to do the back surgery. Here's the MRI, see the lesion, okay, see you next Tuesday. Talk to the anesthesia guy the day before, get your CBC, and I'll see you post-surgically because you'll be asleep when I come by to do the operation. And, it's obviously even more complicated than that, but unfortunately there's a reason that American medical care is twice as expensive as every other country, and the outcomes are no better. Sorry, you set off, you touched the nerve there.
Well, it's good to know that there's research. I had a patient every 6 months to get an appointment with Dr. Ho, who's psychiatry out at
Ho is great.
And the secretary on the phone said, just so you know, we don't prescribe things, which the patient was thrilled about. So it was interesting thing.
Right, because sometimes people come to us and, it takes about 2 hours to have an evaluation. Occasionally, 30 minutes in, the patient stands up and says, so am I going to get my oxycodone or not? I thought you were a pain service. What's wrong with you guys? And so one key question, I don't know if you guys are in a position to ask it, is, are you here for help with your pain, or are you looking for a source of opioids? Those are 2 different directions. What else? Yeah.
So I work on the ortho and trauma floor over at Upstate, and I know we talk about it all the time. So we see this a lot. People that are saying that opioids, and then they're either here for an elective surgery for the pain, or they get a car accident, now they have trauma, your service will work that. You guys know that I absolutely understand the rationale for that. So do you have any tips for how we can get that on a day-to-day basis. We're on the floor with them, and they're screaming in agony.
Right. So if you just got run over by a truck, it's not a good time to have your detox.
Right.
So we'll often say, give them 2 or 3 times what you would normally give. The pain complaints are very legitimate because of opioid-induced hyperalgesia. So something that wouldn't hurt most people, like sticking your forearm in ice water, it's not great, but it's not terrible. But it hurts the people on opioids so much, so when they're screaming in pain and saying it's not enough opioid, they're telling the truth. That's no time to detox them. I'm always saying, do not give them benzos, right? Because then they say, I'm anxious. What does that mean? Well, on our service, anxiety is a signal that 100% of us humans get when there's something wrong with human relationships. It's a signal. But they're in the hospital. They're maybe not the most honest people. They have difficult lives. They're anxious. They feel alone. They want clonazepam and lots of oxycodone. We ask the surgeons to tell them, we can't give you clonazepam if we're going to give you lots of oxycodone, because sooner or later we're going to find a patient dead in bed, and it happens. So if you want more oxycodone because you're hyperalgesic, we're going to give it to you now, but we're not going to give you clonazepam. No sedating medicine along with opioids. It's just too dangerous. And then you give them my card, or 464-3130. Wait until a month after your surgery and then go get detoxed. It's not the right time to do it usually in an acute setting. Yeah.
I have a question from the web. So first, I'm a home care. I've encountered before when patients have so much pain they can't take it to home. What would you do in a case like that?
So should I repeat the question?
Sure.
So what if you're a home care physical therapist and people are in such excruciating pain that they can't even leave their home? Now, I'm assuming that the reason for this is they have some sort of an injury, maybe a chronic injury, maybe it's a chronic pain, and they're maintained on opioids, and the pain is so bad that they can't leave their home. The most likely cause of that is opioid-induced hyperalgesia. So what you would say as a physical therapist is 30 minutes before I arrive, if you're on oxycodone 20 QID, I want you to take 2 oxycodone because we really have to get that body going. It's just going to deteriorate. If I keep listening to you say this hurts and that hurts, you're going to get worse and worse and worse and weaker, and we're always saying that if your bony architecture is distorted, it's your muscular system that you must have to hold everything together, and that needs to be as strong as possible. And that's why we're asking you to walk down the sidewalk to the physical therapy department and learn how to build up the muscles that hold you together. So take a double dose before I come over, and then let's figure out how to get you off these opioids. Because I understand the A process, every oxycodone is helping, it really is, but the reason that you're housebound with really severe pain is opioid-induced hyperalgesia. And you run into people who have gotten into this process for years and everything is getting worse and they're becoming less functional. The other thing we see when we detox people is suddenly they start to do stuff. There are many studies about this. So if you're a primary care doctor and someone comes for back pain and you say, take some aspirin and go to work tomorrow, those patients have very good outcomes. If you say, oh my God, look at this back, we're going to put you on oxycodone and bed rest for a week, there's a huge amount of disability that's generated by that approach. People maintained on opioids become disabled. People taken off opioids start to get normal functioning again, both in terms of human relatedness, and they'll say they have so much more energy, and their relatives really see this. You know, Jennifer or Jason was just laying around on the couch all day and sleeping on oxycodone. Now we've got him back, and they do stuff. So, and it will include engaging in physical therapy.
I have a follow-up to that. My understanding, maybe I'm wrong, but if someone's that bad and there's so much pain in their organization, how there are options for inpatient detox?
By and large, no. We do 100% outpatient detox for everything. You know, what about someone who is so sick that they can't even get to an outpatient doctor's visit? Well, you know what? You don't run into people like that very often. Occasionally we detox people from nursing homes, and it's a complicated thing, and they come in with nursing home personnel, but they do get to us as an outpatient. The alternative, which is annoying me, is 94% of all detoxes in the United States are done in hospitals. For example, your tax dollars at work, $330 million of Medicaid money is given to inpatient detox facilities like they have at Krause Hospital. 80% of the patients who complete their inpatient treatment don't ever go for another appointment, and the most likely next treatment after you've been hospitalized for a detox is to get hospitalized for a detox. So I'm having a giant fight with the licensing agency in New York State, Oasis, right now, and they do that thing you see often. Their official words are, boy, do we want outpatient detox, and their behavior is, oh, no, we're not going to let you at University Hospital put our patrons out of business. So they have been objecting to our license application for 2 years so far, and my last conversation with Oasis was at Senator DeFrancisco's office, who really gets that this is going on, and I think for the first time we may eventually get our license. Yeah.
This represents an incredible amount of work. Is there some sort of white paper or something that we can, bring to our physicians to give us conversation?
Okay. Beware of asking Brian Johnson for evidence-based stuff, because I will clog your email. You know, I'm trying to give the citations here. To me, there is such overwhelming, conclusive evidence in paper after paper. So my email is johnsonb, because I'm Brian Johnson, johnsonb@upstate.edu. Or, maybe I can send some basic handouts to Adam, and he can circulate them through whatever your group email is. But, oh, my God, the trouble is there's so much information. I told you the first book on opioid-induced hyperalgesia came out in 2010 by Mao, and it's a compendium of about 10 articles by various experts. I wouldn't even know where to begin because there's so much evidence. That Norman Miller 2006 study, one of the findings was the more opioids the patient is on when they come to detox, the more improvement they have in their pain. I don't know what else to say. So what else should I say? Yeah.
So I'm a student, and what I'm wondering is, I think going to graduating this year, if I were going to outpatient, I don't know how to come to this higher patient state. Or medication and what this So what I'm wondering is if I should have a conversation with Dr. prior to telling them to take more medication before.
Right. And no, I understand exactly what you mean, because all you need is the patient saying, what's your name? Anna. If it wasn't for Anna, I wouldn't be out of oxycodone 8 days early. She told me to take all those pills. So you have to play it according to each patient. Sometimes you're going to have to call a doctor. Sometimes you can say, like I'm saying, if it's QID dosing or every 4 hours dosing, which then means 6 pills a day, take 30 minutes before you come in for our work together, and don't take extra pills overall, but just it's going to hurt. You're hyperalgesic, so that's the only treatment there. Either you're going to go up and up and up in the dose for hyperalgesia until people stop breathing, which you saw is happening all the time, or you get off. So when you're in this in-between land, everyone's half miserable, including the physical therapist, and you play it the best way you can. The goal of the talk is so you guys understand what you're dealing with here. Yeah.
My understanding is that there's some research that suggests that across individuals there are substantial differences in terms of how much opioid medication is needed to get pain. Individuals have not been on opioids before, and there are these physiological differences across individuals.
What are they? What are the physiological differences?
That perhaps there's a difference in the numbers and distribution of different types of opioid receptors within individuals. Does that?
Has someone been looking at all those individual differences?
I'm wondering if it makes more individuals more likely, if there is that difference to develop.
So this.
What I'm thinking about outline.
All right. So.
Who become perhaps more readily develop OIH, or who don't. Are there percentages, guidelines?
Right. So the question is, what's your name? Jan. So Jan is saying, what about individual differences, different receptor systems, different genetics? Okay, so there's an SCN9 gene, and it does affect pain sensitivity. So now there's a guy at Upstate who's working on it, and I can't remember his name right this minute, but it's in about 20% of the population. And if you have one genetic variant, you're kind of average. If you have one genetic variant, you have increased pain sensitivity. And if you have another genetic variant, you can't feel pain at all. So did anyone read or see The Girl with the Dragon Tattoo? Yeah, there's that bad guy, the main woman there, her brother has no pain sensitivity, and the boxer is trying to beat him up, and he doesn't feel any. That is a real thing, although I'm sure it's very uncommon. So this guy, Jay Reeder, R-E-A-D-E-R is the guy's name. He's a basic science researcher at Upstate, and what he found was that in people with interstitial cystitis, which is that weird condition, like no one knows, like, what's up with the bladder. You have some people who complain, oh my God, my bladder hurts, and they've had 4 examinations, and there's nothing different about their bladder that anyone can find, so it's labeled interstitial cystitis. The variant, which is 20% in the general population, is 50% in people with interstitial cystitis. So there must be different genetic variants. Now, how does that interact with practice? If you're paying attention, one of my points here is we don't know what we're doing. We don't really understand the whole pain system. We're treating millions, probably half the 3% of all Americans are now maintained on opioids for chronic pain. So we're giving these drugs out all the time, and we're probably creating all kinds of changes in people's body. I have a book. If you ever want to Google Brian Johnson, MD, and zombies, you'll find my book, which is for teenagers about addiction. And it has the story that I was out on my bike at the end of my marathon running career, and somehow I caught my pedal on the curb going around a corner, slammed to the ground, broke my ulna in half, and fractured my acetabulum from the bottom to the top. And, I'm bleeding all over, and I get to my hospital, which was B.I. Deaconess at the time in Boston, and I made them give me a plexus block, they call it the brachial plexus block, no general anesthesia, no opioids. The orthopedic surgery fellow comes by at 11 o'clock after they put a giant screw in my ulna, and the guy says, I'm here to give you patient-controlled anesthesia. And I said, no thanks. And he goes, I'm putting this here because you're not waking me up in an hour when you're screaming in pain. So it's just, I took acetaminophen for a day and a half. It was my hospital, and my residents and attendings came to visit me, and a lot of the opioids are being given because they're great for anxiety, but no one's saying that. And if I moved my pelvis, it killed. So you know what I did? Like, doctor, every time I do this, it hurts. What should I do? I moved my pelvis. About a week later, it stopped. Whatever those two sides were grinding together, and I just didn't move. And, it's like, let pain be your guide. Pain is there for a reason. And was it overwhelming? My first thought when I realized I had multiple fractures was, this is great. I'm going to find out, from the inside, how bad is the pain when you get multiple fractures. And you know what? It's not that big a deal. All right, so you got me there. Yeah, Karen.
Into where somebody can have that conversation with a prescriber. And then we can talk to several of these areas.
Well, but the prescribers are already prescribing tons of junk, right? It's just a matter of, why don't you take your junk before you come see me? But whatever, we're back to Anna's point that, every person is a different case, and you don't want to get in trouble. All right, one more question.
So I love the idea of this whole primary test, but we don't have access to that. So if we're evaluating somebody with a primary pain, are you aware of any tests? I'm sure not specific to that, but any tests that we could do, or typically not under stimulus we could apply that they say, wow, that really hurts, that makes us start to think down the road?
Yeah, I'm afraid that, having read all about that, this is okay, but there's really no other way that there is to measure pain tolerance. So we're back to if they wrecked their back in 2004 and it hurts twice as much now as it did 9 years ago, that's opioid-induced hyperalgesia. And you really do see the pain spread. It was a L4-5 spinal fusion, and it's not just the adjoining vertebral joint that's hurting. It's hurting all up and down the spine. That's probably opioid-induced hyperalgesia. Now my neck is hurting. Oh, gee, do I need another MRI? you can spend $2,000 for another MRI, or you can send them to my service. We'll take them off the opioids, and we'll find out if their neck still hurts. All right, thanks, everybody. Great, thanks. Thank you so much for having me.